I remember the exact second I realized 9 years of medical certainty might be wrong. It took less than 3 seconds, and it happened in my ER at 1:12 in the morning. Night shift was quiet in that suspicious way hospitals get, right before something complicated walks through the door. Not dramatic, not chaotic, just that low hum of monitors and half-finished chart notes. I was finishing a discharge when triage called about an 18-year-old female syncopal episode at home, history of chronic lower limb paralysis, wheelchair dependent. That part didn't surprise me. Dehydration and fainting happen. What did catch my attention was the last line in the chart summary. Static congenital motor impairment. Permanent. Permanent is a heavy word. We don't use it lightly. At least we're not supposed to. They rolled her in looking more embarrassed than sick. Emma Callahan. Thin. Alert. No distress. Her father followed right behind the stretcher posture, straight movements controlled. You could spot military from across a parking lot. Commander Mark Callahan, U.S. Navy SEAL, active duty. He didn't introduce himself like it was a flex. He said it like it was context. We got vitals first. Mild dehydration. Orthostatics positive. Nothing dramatic. I asked the basic questions. Any chest pain? Number shortness of breath? Number hit your head? No. Her voice was steady. Stronger than I expected from someone who had spent 9 years being described as medically fragile. Once she was settled, I did what I always do. I stopped reading and started examining. Her legs rested on the stretcher, thin but not wasted. I tapped her patellar tendon. Reflex intact. I checked her ankles. Same. No clonus, no abnormal plantar response. I tested tone gently. It wasn't flaccid. It wasn't spastic. It was guarded. That's the only word that fit. I looked back at the chart to make sure I hadn't missed something obvious. 3MR is over the years. EMG studies. Genetic testing. Pediatric neurology consults in 2 different states. Final classification, non-progressive motor impairment. Permanent. I've treated real spinal cord injuries. When the cord is truly damaged, the exam tells you. It doesn't whisper. It doesn't hedge. It's clear. Emma's exam wasn't clear. Her father stood near the wall, watching me without hovering. I've met a lot of protective parents. He wasn't loud. He was precise. Like he'd already processed every bad possibility and filed them neatly away. Has anything changed recently? I asked him. No, he said. This is her baseline. Baseline. Another word that closes doors. I asked Emma to try lifting her right foot. She inhaled slightly before she even attempted it. Her quadriceps tightened. Her hip flexors co-contracted. The foot didn't move. But the tension did. Most people wouldn't notice that difference. I did. I crouched so I wasn't towering over her. Before you try to move, I said, "What does it feel like?" She frowned, thinking about it. Not confused. Thinking. Like it's locked, she said finally. Not gone. Just locked. That was the moment. That 3-second shift. Locked is not the same as paralyzed. I didn't react. I didn't look at her father. I kept my tone neutral. When did it start feeling that way? I don't know, she said. It's always been like that. Her father crossed his arms. She was diagnosed at 9, he said. We've had every test you can name. I nodded. I'm sure you have. And I meant that. Families like his don't ignore things. They mobilize. They escalate. I gently placed my fingers along her ankle. Don't try to move it, I said. Just imagine moving it. She looked at me like I'd asked her to solve a math problem without numbers. Just imagine. Yeah. No effort. No pushing. She closed her eyes. Nothing happened at first. That was expected. Motor imagery isn't magic. It's subtle. Then I felt it. A brief, faint recruitment along the anterior compartment. Not a reflex. Not a jerk. A whisper of voluntary activation. Her toes didn't lift, but the signal was there. I tried again. Still not trying. Just think about it. This time, the smallest visible twitch flickered at the tip of her right big toe. So slight you'd miss it if you blinked. Her father straightened. Did that? I held up a hand, calm. Let's do it one more time. She inhaled, focused. The toe shifted again. Maybe an inch, maybe less. That wasn't a withdrawal reflex. There was no stimulus, no painful input, no sudden stretch. That was intent. Right there in a quiet ER bay with a dehydrated patient and a chart that said permanent, I felt my stomach drop. If she could recruit motor units voluntarily, even minimally, then something didn't line up. And if something didn't line up, then 9 years of documentation might not be the whole story. The terrifying part wasn't that I might be wrong. It was that I might be right. If you've ever seen something in a hospital that didn't match the paperwork, drop a comment below. I read them. And if real ER stories like this matter to you, subscribe so you don't miss what actually happens behind those doors. Emma opened her eyes. Did I move it? A little, I said. Her father looked at me carefully. Are you saying she can walk? No, I said immediately. I'm saying I don't like using the word permanent unless I can prove it. He didn't smile. He didn't argue. He just absorbed that. I stood and reviewed her old imaging reports again. The earliest MRI mentioned a questionable signal at T9. Not definitive. Follow-up scans reportedly stable. No progression. No structural collapse. EMGs over the years showed reduced recruitment but not absent activity. Reduced is not the same as absent. I documented carefully. Motor findings inconsistent with complete structural lesion. Further evaluation recommended. That sentence alone could trigger questions. Questions hospitals don't always enjoy. Her father stepped closer, lowering his voice. Doctor, he said, are you telling me someone got this wrong? I met his eyes. I'm telling you I don't have enough evidence to call it permanent. He nodded once. That was all. Outside the bay, monitors kept beeping. A trauma page echoed overhead. Normal ER noise, ordinary chaos. Inside that curtain, something had shifted. Emma flexed her foot again without me asking. The movement was weak, trembling, but it was there. And for the first time since she was 9 years old, I don't think she was just imagining it. I kept my hand near her ankle a second longer than necessary, feeling for something I could defend in writing. Emma flexed again, weaker this time, like the signal had to travel through resistance. Her father saw it too. He didn't celebrate. He didn't even smile. He just shifted his weight forward like a man who'd been standing at attention for 9 years and finally allowed himself to lean. I want to see her full chart. I said more to myself than anyone else. We have copies, he replied immediately. Of course he did. Within 10 minutes, a thick binder was sitting on the counter in the ER bay. Tabs, dates, reports from hospitals in Virginia, Florida, and California. When a Navy family moves, their medical records travel like deployment orders. I flipped to the beginning. Age 9. Fall at school. Brief loss of consciousness. Back pain. MRI performed. The original radiology report described a faint hyperintensity at the T9 level. The wording was cautious. Questionable signal change. Clinical correlation recommended. That's radiology language for, we're not sure. A pediatric neurologist consulted 2 days later wrote, motor exam inconsistent. Consider repeat imaging if symptoms persist. 3 months after that, another note appeared. Persistent lower extremity weakness. Functional overlay cannot be excluded. I paused there. Functional overlay. That phrase gets used when symptoms don't fully match structural findings. It's not an insult. It's not dismissal. It's medicine saying, there may be more happening here than what the scan shows. I turned the page. 6 months later, a different neurologist MRI stable. No progression. Likely static injury. Recommends supportive therapy. The word static showed up for the first time. By year 2, the language hardened. Chronic motor impairment. Non-progressive. Permanent. Permanent without definitive structural damage. That shift didn't happen overnight. It happened gradually, note by note, specialist by specialist. No single dramatic mistake, just momentum. I looked up at Commander Callahan. Did anyone ever explain what caused the initial signal change? They said it might have been a contusion, he answered, or artifact. Depends who you asked. And after that, they said she wasn't improving the way they expected. Improvement is a tricky benchmark in kids. Some get better fast, some plateau. But plateau doesn't automatically mean permanent. Emma watched me flip pages. Is that all about me? She asked. Yeah, I said. 9 years of you. She shrugged like it was a school project someone else completed. I kept reading. EMG study at age 10, reduced voluntary recruitment, no denervation potentials. Repeat at 12 similar findings. No progression. No evidence of lower motor neuron loss. Reduced recruitment can mean many things. Pain, fear, guarding, lack of effort. It can also mean real neurologic compromise. Context matters. What I didn't see anywhere in the chart was a clear lesion that explained total loss of motor function for nearly a decade. There was also something else missing. No structured evaluation for functional neurological disorder. No documented motor imagery testing. No graded exposure plan. The assumption seemed to be that once improvement didn't occur within a certain window, the system settled. I've seen this before. Not exactly like this, but close enough. When one physician writes permanent, the next one reads it before touching the patient. And once it's in bold in the problem list, it carries weight. Insurance coding relies on it. Disability accommodations rely on it. School systems rely on it. It becomes administrative truth. Challenging that truth isn't just clinical. It's legal. It's financial. It's reputational. I closed the binder halfway and stepped outside the bay to page neurology. Dr. Victor Hale answered within minutes. He was efficient, controlled, and very aware of his department's record. I reviewed her case earlier this year. He said after I summarized what I'd seen, "There's no new structural finding." "I'm not convinced it's structural," I replied. Silence on the other end. "Rachel," he said carefully, "this has been evaluated extensively." "I know. I've read it. And I'm not sure anyone's reevaluated the assumption. You're suggesting functional weakness. I'm suggesting it hasn't been ruled out." His tone shifted slightly. "Functional diagnoses require caution. You risk implying prior error." "I'm aware." "And you're in the ER. That part wasn't subtle." "I am," I said. "And she presented here. So I'm evaluating what's in front of me." He exhaled through the phone. "What exactly did you observe?" "Voluntary recruitment with motor imagery. Subtle but reproducible. That can be misinterpreted. So can permanence." Another pause. "I'll come down," he said finally. When I walked back into the bay, Emma was watching her own foot like it had betrayed her. She flexed again, testing it without me prompting. Her father looked at me. "Is this good news?" he asked. "It's information," I said. He nodded. "That's more than we've had in a while." That statement bothered me more than it should have. 9 years is a long time to live on autopilot inside a diagnosis. I reopened the binder and skimmed the school records attached at the back. Individualized education plans, mobility accommodations, notes from counselors. One line stood out from a report when she was 11. Emma expresses frustration that her legs won't listen. Won't listen is not the same as can't function. I returned to the medical section. In year 3, a note from a consulting specialist read, "Family appears well-adjusted to disability status." That phrase is subtle. It means the family has accepted the diagnosis. It also means fewer people are likely to question it. Emma cleared her throat. "Am I in trouble?" she asked suddenly. "No," I said immediately. "Why would you be?" "Because every time I try and it doesn't work. Everyone gets quiet." That hit harder than any MRI report. Her father turned toward her. "You're not in trouble?" She nodded, but she didn't look convinced. Dr. Hale stepped into the bay a few minutes later, professional expression locked in place. He greeted the family, then me. "Show me," he said. Emma looked between us, unsure. I didn't argue. I didn't defend my impression. I just said, "Emma, remember, don't try. Just think about lifting your right foot. She inhaled. The room felt smaller, and I watched very closely to see what he would call it. Dr. Hale folded his arms and stepped closer to the stretcher without saying a word. Emma kept her eyes on her right foot like it might embarrass her in front of an audience. I didn't change my tone. I didn't dramatize it. Same thing, I said. Don't try, just imagine. She swallowed and closed her eyes. Nothing happened at first. That's the part people misunderstand. When something is real, it's rarely cinematic. It's subtle. It's awkward. It takes a second. I watched her anterior tibialis carefully. The muscle twitched under the skin before the toe moved. That order matters. Reflexes don't recruit that way. There, I said quietly. Her big toe shifted. Not much. A flicker, but controlled. Dr. Hale didn't blink. That could be reflexive. There's no external stimulus, I replied. Internal focus can still produce non-purposeful movement. I nodded. Then let's repeat it. Emma opened her eyes briefly. Am I doing it wrong? No, I said. You're doing exactly what I asked. She shut them again. This time the movement was delayed, like the signal had to push through resistance. The toe lifted slightly higher, maybe half an inch. Then it dropped. Her father leaned forward. That's voluntary, he said, not asking. Dr. Hale held up a hand. Let's be careful with language. That's how these conversations go. It's not yelling, it's definitions. He stepped closer to examine her foot himself. He tested for clonus. None. He ran the handle of his reflex hammer lightly along the plantar surface. Minimal response. Lift your foot, he said directly to Emma. Her jaw tightened. Her quadriceps fired hard. The foot didn't move. He looked at me. You see the difference? I do, I said. When she attempts direct movement, nothing. When she's distracted or imagining, you get inconsistent motor activity. That's not functional recovery. That's variable effort. I kept my voice even, or variable inhibition. He didn't like that. Inhibition suggests preserved pathway, he said, yes. And preserved pathway contradicts 9 years of evaluation. It contradicts a complete structural lesion. He straightened slightly. No one has documented a complete transaction. Then why permanent, that hung in the air longer than the twitch had? Her father spoke before Hale did. That's what we were told. Dr. Hale turned to him calmly. Commander permanence in this context refers to long-standing non-progressive impairment, not necessarily absence of neural tissue. That's not how it was explained, Callahan replied. I watched Emma during this exchange. Her shoulders were rising slowly toward her ears. Guarding again. The more we debated, the less she moved. Emma, I said gently, can you do that imagining thing again? She nodded faintly. Don't think about lifting. Think about your foot being light. She almost smiled at that. Like helium. Sure, I said. Medical helium. Even Dr. Hale exhaled at that. She focused again. I watched the muscle. The activation was there before the movement. That sequencing matters. It tells you the brain is sending something even if the body doesn't fully cooperate. Her toe lifted. Slight. Controlled. Then dropped. Dr. Hale knelt to get closer. Emma. Are you consciously moving that I'm thinking about it? She said. Are you trying to trick us? He asked gently. Not accusing, but testing. She looked genuinely confused. Why would I do that? Her father's expression hardened at the question. Hale raised a hand slightly. It's a clinical question. I stepped in. She's not demonstrating inconsistency. She's demonstrating recruitment under low-threat conditions. That's speculation. It's observation. We were both careful. Neither of us raised our voices. But the tension wasn't subtle. I turned to the monitor where her vitals displayed steady numbers. No tachycardia. No stress spike. She wasn't anxious in a dramatic way. She was contained. Emma, I said, when you try hard to lift your foot, what happens? It feels heavier, she said. Like it doesn't want to. Does it hurt? No. Does it feel numb? No. Then what? She thought for a long second. Like if I try and it doesn't work, everyone gets disappointed. That wasn't a neurologic symptom. That was conditioning. Dr. Hale stood slowly. We need to separate psychological overlay from structural pathology. I agree, I said. He glanced at me. Careful. I am. He checked her hip flexors manually. With passive movement, range of motion was preserved. No contractures. That alone was unusual after nearly a decade of supposed paralysis. Has she been in continuous physical therapy? He asked the father. Yes, Callahan answered. Maintenance. Range of motion. Strengthening where possible. So the muscles hadn't fully wasted. That explained some of what I was seeing, but not all of it. Dr. Hale stepped back and folded his arms again. At best, he said quietly to me, you're describing functional neurological disorder. At minimum, I said. That diagnosis carries implications. So does permanent. He looked at me carefully. Do you understand what you're implying? Multiple institutions? Multiple specialists. I understand I'm describing what I see. And what do you see? I didn't hesitate. Preserved pathway with maladaptive inhibition. He studied me for a long moment. That's a strong claim for an ER encounter. It's not a claim. It's a differential. Her father looked between us like he was watching a tactical briefing. If she has preserved pathway, he said slowly, does that mean she can walk? I chose my words carefully. It means I'm not convinced she can't. Emma blinked at that, like someone had shifted the air pressure in the room. Dr. Hale exhaled. We need controlled evaluation. I agree, I said again. He nodded once. Formal assessment. Physical therapy lab. Observed. That's fair. Emma looked suddenly tired. Am I staying? She asked. For now, I said gently. We need more information. Her father placed a steady hand on the rail of the stretcher. We'll stay. As Hale stepped out to arrange the evaluation, I felt the weight of what had just happened settle into my chest. It wasn't the twitch that scared me. It was the fact that I could defend it. I watched Dr. Hale walk out of the bay with that measured pace specialists use when they're thinking 3 steps ahead. Emma shifted slightly on the stretcher, like the air had gotten heavier. Her father stayed close, not hovering. Just present. I finished her IV fluids and updated her orders while pretending my heart rate wasn't higher than it should have been for a syncopal workup. 15 minutes later, my phone buzzed. Conference room B, the message read. No emoji, no context. That's hospital language for you're about to be reminded where you stand. I stepped into conference room B, still wearing my stethoscope, because ER physicians don't get wardrobe breaks for administrative tension. Inside were Dr. Hale, Cynthia Morales, our chief medical officer, and Thomas Whitaker from Hospital Legal. If you ever see legal at a meeting before breakfast, it's not about coffee quality. Cynthia gestured for me to sit. Rachel, we just want to clarify what was observed. Clarify is another heavy word. I documented inconsistent motor findings, I said evenly. Preserved reflexes. Voluntary recruitment with motor imagery. Whitaker leaned forward slightly. And you used the term inconsistent with complete structural lesion. Yes. Do you understand that statement suggests prior misclassification? I understand it suggests the current classification may not be comprehensive, Hale interjected. Functional diagnoses must be approached carefully. The literature is clear about risk of overdiagnosis. I'm not overdiagnosing, I replied. I'm underaccepting. Cynthia held up a hand. No one is accusing anyone of error. We're discussing risk. Risk. That was the center of the room. Whitaker opened a folder. If the word permanent was applied without definitive structural evidence that becomes discoverable in litigation. Litigation against us, I asked. Potentially multiple institutions, he said, including those in other states. That creates cross-jurisdictional exposure. Translation, if you're right, this gets messy. Hale's tone stayed controlled. Rachel, what is your clinical objective here? To determine whether preserved motor pathway exists, and if it does. Then permanent is inaccurate. Silence. Cynthia leaned back in her chair. This patient has had stability for 9 years. Functional status accommodations established care plans. Disrupting that has consequences. Stability isn't the same as accuracy, I said. Whitaker tapped his pen once. If you document suspicion of prior error, we are obligated to initiate review. That's not a threat, Cynthia added quickly. It's process. I nodded. Then initiate review. Hale's eyes narrowed slightly. You're confident. I'm careful. He folded his hands. What do you propose? Controlled evaluation. Physical therapy lab. No leading commands. Observed environment. Cynthia looked at Hale. He gave a small nod. Fine, she said. But language matters. We are not calling this misdiagnosis. I haven't, I said. Whitaker closed the folder. Until there is definitive evidence, documentation should reflect evolving clinical picture. Evolving clinical picture. That's how medicine admits it may have been wrong without using the word wrong. The meeting ended without raised voices. That's how institutional tension works. It's quiet. It's polite. It's sharp. When I walked back to the ER, Emma was sitting up scrolling through her phone. Her father looked up immediately. Everything okay? He asked. For now, I said. We're moving her to the physical therapy lab for formal evaluation. He studied my face. Is that good? It's necessary. Emma tilted her head. Am I in trouble with the hospital? No, I said. You're in trouble with gravity. We're going to test that. She gave me a small smile at that. Transport arrived with a wheelchair, and that detail wasn't lost on anyone. She transferred smoothly with upper body strength that told a story of years adapting. As they rolled her down the hallway, staff glanced over casually, unaware they were passing a case that might rewrite its own narrative. The PT lab was larger than an ER bay. Bright open, less forgiving. Cameras mounted discreetly in corners for documentation. 2 physical therapists waited. 1 clipboard, 1 tablet. Dr. Hale entered a few minutes later. Cynthia stood near the wall. Whitaker did not attend. Legal prefers distance during observable events. Emma was positioned on a padded therapy table. Blood pressure stable. Heart rate slightly elevated, now likely situational. Emma Hale began professional and measured, We're going to run standard motor assessments. She nodded. Lift your right leg. Her jaw tightened. Quadriceps engaged. No movement. Again, same effort, same result. I watched her shoulders. They crept upward again. One of the therapists documented quietly. No active movement. Hale looked at me without speaking. There it is, his expression said. Emma, I said calmly, remember earlier. Don't try. Just imagine. Hale glanced at me but didn't interrupt. She closed her eyes. The room got quiet in that particular way medical rooms do when everyone pretends not to be holding their breath. Nothing happened for a few seconds. Then I saw the muscle activate before the leg moved. The foot shifted slightly off the table. Not dramatic, but visible. The therapist looked up. Did you see that? Yes, I said. Hale stepped closer. Repeat. Don't try, I reminded her softly. She inhaled again. This time the movement was smaller, less confident. The pressure of observation was creeping in. Hale adjusted his stance. Emma focus. And just like that, the movement stopped. That detail mattered more than the twitch itself. I looked at him. Everyone step back, I said quietly. He hesitated. 5 feet, I added. Cynthia nodded slightly. Hale complied. The therapists moved back as well. Emma remained on the table, eyes closed. No one spoke. 30 seconds passed. Her right foot lifted. Clear. Controlled. 2 inches. The therapist lowered her clipboard slowly. Hale didn't say reflex this time. I felt my pulse in my ears. Because now, this wasn't a question of whether I had imagined something in a noisy ER bay. Now it was documented. Observed. Replicated. And that changed the math inside the building. I kept my eyes on her foot instead of on Dr. Hale because the muscle doesn't care about hierarchy. Emma's right foot hovered for maybe 2 full seconds before lowering back to the table. It wasn't dramatic. It wasn't a miracle. It was controlled, and that's what mattered. One of the physical therapists cleared her throat quietly. "That was active," she said, almost apologetically. Hale didn't answer her right away. He stepped forward again, careful not to crowd the table. "Emma," he said evenly, "this time I want you to lift your leg when I say 3. Her shoulders rose again. I saw it immediately. 1, 2, 3. Quadriceps engaged. No visible movement. He looked at me. "You see the variability. I see inhibition under command," I said. "That's interpretation. So is reflex." Cynthia, still by the wall, spoke calmly. "Let's standardize this." The therapist adjusted Emma's position slightly, making sure her hip was neutral and supported. "Okay," she said gently. "Emma, we were going to try it both ways again." Emma nodded, but she looked tired now. Not physically exhausted. Emotionally. "First direct command," the therapist said. "Lift your right leg." Nothing. Now I said softly, "Just imagine it floating." No countdown. No performance. Emma closed her eyes again. No one moved. Even the fluorescent lights felt louder. There it was. The muscle fired. The leg lifted off the table. Clear separation. Not a flicker this time. A controlled elevation of about 3 inches before lowering. The therapist inhaled sharply. "That's not passive." Hale stepped closer to inspect the angle. "Emma," he said, tone still neutral, but tighter now. "Did you feel that?" "Yes," she said. "Did it hurt?" "No." "Did you force it?" "No." I crouched slightly so I could see her face. "What did it feel like?" "Like I wasn't trying to win," she said. That line hit everyone in the room differently. Hale straightened. "We need objective data." "I agree," I said. "Repeat EMG during motor imagery and direct command." The therapist nodded. "We can set that up." Within minutes, surface EMG leads were placed along her anterior tibialis and quadriceps. No drama. Just wires and adhesive pads. The kind of setup that removes opinion from the equation. "Direct command first," Hale said. Emma tried. The monitor showed increased proximal co-contractions, scattered firing, but no coordinated motor unit recruitment sufficient for lift. "Now imagery," I said. She closed her eyes again. The EMG trace spiked differently this time. Cleaner. More focused recruitment. The graph doesn't lie about pattern, even if it doesn't explain why. The therapist pointed to the screen. "That's organized activation." Hale leaned closer. "It's present." "Reduced but present," I added. Emma's leg lifted again. 3 inches, then down. Her father, who had remained silent the entire time, let out a breath he'd probably been holding since she was 9. "So she's not paralyzed," he said quietly. No one rushed to answer that. "Paralysis isn't binary," Hale replied carefully. "There are central and peripheral components. But the pathway is there," I said. He met my eyes. Yes. That single word shifted the tone in the room more than any argument had. Cynthia stepped forward now. "If the pathway is present, we're not dealing with a complete structural lesion." "No," Hale agreed. Emma opened her eyes and looked between all of us. "Does that mean I messed up the tests before?" "No," I said immediately. "You didn't mess up anything," the therapist added. Hale's voice softened slightly. "It means we may need to reconsider how we've been testing." Emma looked at her father. "So I'm not broken?" He swallowed. "No." I stepped in before the moment tipped too far emotionally. "We don't use that word in medicine anyway." That got a faint smile from one of the therapists. Hale turned to me. "If this is functional neurological disorder, we need to document carefully." "It's a working diagnosis," I said. "Not a declaration. And if it isn't, then we'll prove that too." He nodded once. "We'll need repeat imaging to rule out missed structural change." "That's reasonable." Cynthia looked between us. "And we manage communication carefully. No premature conclusions." No one argued with that. The therapist removed the EMG leads while documenting everything meticulously. Timestamps, activation patterns, direct versus imagery comparison. Objective data is protective in situations like this. Emma flexed her foot one more time without being asked. The movement was smoother now, small but smoother. "Can I try standing?" she asked suddenly. Hale and I answered at the same time. "Not yet." She sighed, but she didn't push. Her father placed a steady hand on her shoulder. "We do this right. Right now" meant cautious, controlled, measured. As the session wrapped, Hale turned to me quietly. "You understand this changes things?" "Yes." "Not just clinically. I know." He held my gaze for a second longer than usual. "We move forward systematically. I wouldn't have it any other way." Emma transferred back into her wheelchair with practiced efficiency. As they rolled her out of the lab, the atmosphere felt different. Not lighter, more alert. Data had shifted from ambiguous to uncomfortable, and uncomfortable is where real medicine starts. Back in the hallway, staff who hadn't witnessed the session had no idea anything unusual had occurred. The hospital kept moving. Admissions, discharges, lab draws. It all continued. Inside the therapy documentation, though, the words were already changing. Voluntary motor activation observed. That phrase alone was enough to unsettle a decade of assumptions. Emma looked down at her foot again as they paused by the elevator. She flexed it gently, testing it like it belonged to her for the first time in years. It moved. And this time, no one called it reflex. I watched the elevator doors close on Emma and her father, and for the first time that night, the word permanent felt reckless. Back in the conference room, it was just me, Dr. Hale, and Cynthia. No therapists, no patient, no emotion in the room to soften what needed to be said. Hale leaned back in his chair. "All right," he said. "Let's talk about what this actually is, functional neurological disorder," I replied. He didn't disagree. Cynthia folded her hands. "For documentation purposes, define it clearly." Hale answered before I could. FND is a condition in which neurological symptoms are present without structural damage explaining them. The brain's functioning is altered, not its anatomy. Motor subtype, I added. With preserved corticospinal tract. Likely, he said. "Then why did no one commit to it 9 years ago?" Cynthia asked. That was the uncomfortable part. I reopened the chart on my tablet and pulled up the early consult notes. "It was mentioned once," I said. "Functional overlay cannot be excluded." Hale nodded slowly. Overlay language is often used when physicians suspect psychological contribution but lack certainty. "And then it disappeared," I said. He sighed. "Because it's risky." Cynthia looked at him. "Risky how?" "Parents hear functional and assume we're saying it's imaginary, or that it's their fault, or that it's malingering. It can damage trust." I added, "So instead we defaulted to static injury," which sounds safer. "Safer legally," Hale corrected. There it was. Cynthia's voice remained calm. "If this is FND, what explains the progression to full wheelchair dependence?" "Reinforcement," I said. They both looked at me. When a child repeatedly attempts movement and fails, especially after a traumatic event, the brain can learn to inhibit that pathway. Add repeated medical exams, heightened parental concern, and institutional labeling. The brain adapts. Hale nodded reluctantly. "Learned non-use." "Yes. And fear conditioning," he added. I turned the tablet so they could see a note from Emma's school counselor at age 11. She wrote that Emma described her legs as not listening. That's not loss. That's disconnection. Cynthia exhaled slowly. "So you're saying we didn't miss a lesion? We missed a pattern." "That's exactly what I'm saying." Hale rubbed his forehead briefly. FND in pediatric populations is underdiagnosed, especially in military families. "Why military specifically?" Cynthia asked. "High-functioning households," he said. "Strong emphasis on resilience. Symptoms that don't resolve quickly can become identity. And once identity forms," I added, "movement becomes performance." We sat with that for a moment. Cynthia broke the silence. What about the initial MRI finding? Hale answered. The hyperintensity at T9 was never definitive. No progression, no correlating cord signal change on repeat imaging. If it had been a true structural injury of that magnitude, we would have seen atrophy or spasticity over time. We didn't, I said. No. So the label hardened without the evidence evolving, Cynthia summarized. That's diagnostic momentum, I said. Hale nodded. Once the word permanent entered the chart, it shaped every subsequent evaluation. Confirmation bias followed. Cynthia looked at both of us. Then we need to be precise moving forward. That part wasn't negotiable. Emma was admitted overnight for observation and repeat imaging. Not because I expected new structural findings, but because thoroughness protects everyone. The next morning I stopped by her room before rounds. She was awake, scrolling through her phone again. Her father stood by the window, already dressed like he was heading to a briefing. How are you feeling? I asked. Like everyone's staring at my legs, she said. That's fair. She flexed her foot again, almost casually now. The movement was small but smoother than the night before. Did I do something wrong all these years? She asked suddenly. No, I said immediately. You adapted. To what? To what your brain thought was safest. She frowned. Safest from what? I hesitated, then kept it simple. From failing. Her father shifted slightly at that. Emma looked down. Every time I tried when I was little and couldn't move it, everyone panicked. Teachers, doctors, Dad. He stepped closer. I wasn't panicking. You were? She said gently. Just quietly. That honesty filled the room more than any monitor alarm ever could. I turned to him. Early repeated failure, especially when paired with fear, can reinforce motor inhibition. The brain prioritizes protection. He processed that the way military officers process difficult intel, internally first. So you're telling me? He said slowly. Her brain shut it down on purpose. Not consciously, I said, protectively. He nodded once. Repeat MRI results came back by mid-afternoon. No new lesions. No cord compression. No demyelination. Stable imaging compared to previous scans. Hale reviewed them himself. Structural explanation remains insufficient, he said plainly. That was as close to an admission as I was going to get. We scheduled formal neuropsychological evaluation alongside physical therapy planning. FND requires coordinated management. You don't fix it with one inspirational speech. Emma listened quietly while we explained next steps. Graded motor imagery, gradual load bearing, no dramatic goals, no countdowns. What if I can't do it when everyone's watching? She asked. Then we adjust who's watching, I said. She nodded. Her father looked at me. If this works, he said carefully, what does that mean about the last 9 years? It means we learn from them, I said. He didn't press further. As I left the room, I felt something I hadn't felt at the start of the night. Not relief, responsibility. Because if this truly was functional neurological disorder with preserved pathway, then the terrifying part wasn't that we'd missed it. It was how understandable that miss had been. By the 5th day of therapy, Emma couldn't lift her foot at all. I was standing in the PT lab watching the exact opposite of what I had documented earlier. No activation spike, no visible twitch, just muscle tension without movement. Dr. Hale stood beside me, arms folded but not smug. That would have been easier to handle. Instead, he looked analytical. Direct command, the therapist said gently. Emma tried. Nothing. Motor imagery. She closed her eyes. Nothing. The therapist glanced at the EMG monitor. Flat recruitment. Minimal signal. Hale spoke quietly. This is the variability I was concerned about. I didn't answer right away. Emma opened her eyes, already scanning our faces. Did I lose it? She asked. No, I said automatically. But I wasn't as certain as I had been 2 days earlier. The brain doesn't rewire on command. Functional disorders don't respond to optimism. They respond to repetition, safety, and gradual exposure. But knowing that doesn't make the first setback any easier. Let's take a break, the therapist suggested. Emma nodded and rolled back slightly in her wheelchair. Her shoulders were higher again, guarded. Hale turned to me once we stepped away from her earshot. This is what I meant by destabilizing a long-standing diagnosis. She's not destabilized, I said. She can't activate. She could. He didn't argue with that. He just looked at the data. I walked back toward Emma. Tell me what it feels like right now. Heavy, she said immediately. And loud. Loud how, like everyone's waiting. That was the difference. During the earlier breakthrough, the room had been quiet and spaced out. Today there were more observers. A neurology resident had come by. A second therapist stood near the doorway. Even well-meaning curiosity adds weight. Clear the room, I said. The resident blinked. But clear it, Hale repeated. Within a minute, it was just me, Hale, and the primary therapist. Emma closed her eyes again. Don't try to lift, I said. Just picture your foot moving without you proving anything. Nothing. Her breathing changed. Faster. Stop, I said softly. Open your eyes. She did. I can't, she whispered. Yes, you can, her father said from the corner before catching himself. Sorry. He stepped back further against the wall. That's the paradox. Encouragement can feel like pressure. Hale leaned toward me. We need to consider that prior activation may have been situational. Meaning acute motivation can transiently overcome inhibition. And now the pattern is stabilizing back into paralysis. That's what he didn't say. I crouched in front of Emma. When did it start feeling heavier? This morning, she said. When the therapist said people were impressed. I glanced at Hale. Impressed, she continued, means I have to do it again. That word landed harder than any EMG reading. I stood up slowly. We scale back. The therapist nodded. Return to non-load-bearing imagery only. Yes. Hale looked skeptical, but didn't object. For the next 20 minutes, we removed every performance cue. No observers, no discussion of progress, no mention of improvement. Emma lay back on the table with her eyes closed. Think about your foot resting, I said. She nodded. No lifting. Another nod. The EMG showed faint baseline activity. Not recruitment yet, just signal. Now imagine it feeling lighter, I added quietly. A small spike appeared on the screen. Hale leaned forward but didn't speak. The spike faded. Emma exhaled sharply. I feel stupid, she said. You're not stupid, I replied. You're rewiring. That sounds fake, she said. It's not. Hale surprised me by stepping closer. The brain forms protective patterns under stress, he said directly to her. Changing those patterns takes repetition, not pressure. She looked at him, surprised he was siding with that explanation. So I didn't lose it, she asked. No, he said. We tried again. Imagery only. No movement expected. The EMG spiked slightly stronger this time. Not enough for visible lift, but enough to confirm the pathway hadn't vanished. I felt my shoulders drop for the first time that day. Hale glanced at me. You were right about preserved pathway. I know, but you may have underestimated the reinforcement loop. He wasn't wrong. FND isn't linear. It improves, it regresses, it tests patience, and if you rush it, it pushes back. Emma opened her eyes. I hate that it stops when people watch. That's information. I said. About what? About how your brain associates attention with risk. She thought about that. Her father stepped forward carefully this time. What do you need from me? That question mattered more than any imaging result. Neutral, I said. Not hope, not fear, just neutral. He nodded once. Military training probably helped there. The session ended without a dramatic recovery. No lift, no breakthrough. Just documented minimal activation and a very clear reminder that progress is fragile. As we rolled her back toward her room, Hale walked beside me. If she plateaus again, he said quietly, we need to be honest. I am being honest, I replied. Honest with yourself. I didn't answer immediately, because that was the real risk. Not being wrong in front of colleagues. Being wrong in front of her. Back in her room, Emma flexed her foot absent-mindedly while looking at her phone. No visible movement. But the EMG printout in my hand still showed signal. And sometimes in medicine, signal is enough to keep going. By the third week, Emma could activate her foot on command without looking like she was defusing a bomb. It wasn't dramatic. It wasn't viral video material. It was repetition. Motor imagery twice a day. Low-stakes weight shifts. Gradual load-bearing with a harness system that took most of her body weight so gravity couldn't win by default. The first time she tolerated partial weight through her right leg, she gripped the parallel bars so hard her knuckles went pale. "Just lean," the therapist said calmly. "No lifting. No proving." Emma shifted her hips slightly forward. The harness tightened overhead, absorbing most of the load. Her right knee trembled. "That's normal," I said from the side. "Tremor means recruitment." She looked at me like she wanted that to be true. "Hold it for 3 seconds," the therapist said. "Don't count," Emma replied immediately. The therapist caught herself. "Right. Just hold it. 2 seconds, maybe 3. Then she leaned back into the harness. Her father stood several feet away, hands clasped behind his back like he was on a flight deck. Neutral. He'd learned. The second attempt was better. Less tremor. Slightly more weight through the heel. Dr. Hale watched the monitor displaying load distribution. 30%, he said quietly. "That's enough for today," the therapist replied. Emma shook her head. Again. "No," I said gently. "Stop when it's stable." That had become our rule. We didn't push past clean activation. We didn't chase dramatic improvement. We reinforced safety. Week 4, she stood with 70% support. Week 5, 50. There were still days where she couldn't initiate without imagery first. Still mornings where her leg felt heavy. But the episodes of complete shutdown were shorter. The real shift happened on a Tuesday morning when the harness malfunctioned. It wasn't catastrophic, just a minor calibration delay. The system reset slower than expected, leaving her standing with more body weight than planned for about 2 seconds. Her right leg buckled slightly, but it didn't collapse. The therapist moved quickly to stabilize her. "You're okay." Emma blinked. "I'm holding—" "Yes," I said. She was. Not perfectly, not gracefully, but her right leg was bearing weight long enough for the correction to matter. Hale looked at the load monitor. 85% body weight. Emma's eyes widened. "That's almost all of it." "Almost," the therapist confirmed. We lowered her back into the harness deliberately. Her father didn't say anything. He didn't need to. That wasn't the breakthrough yet. That was evidence. The breakthrough came later that week. We removed the harness entirely but kept the parallel bars. No audience beyond the core team. No residents. No observers. No whispered updates in the hallway. Emma positioned her hands on the bars. Feet aligned. Knees slightly bent. "Just shift," I said. She shifted. Her right leg trembled immediately, muscle fibers firing in rapid bursts. This time she didn't panic when it shook. "That's recruitment," Hale said softly. "I know," she replied. She leaned further. The tremor stabilized. She wasn't fully upright yet, maybe 80 degrees, but she was holding herself. "Don't rush," I reminded her. She inhaled slowly. Shoulders relaxed instead of rising. Then without a countdown, without a cue, she straightened. Full extension through both knees. Upright. Unsupported except for light contact with the bars. No harness. No lift assist. No one touched her. The room didn't explode into applause. We'd learned better than that. The therapist quietly checked the timer. 4 seconds. Emma's breathing sped up. "Keep it neutral," I said gently. "Just stand." 6 seconds. 8. Her quadriceps began to shake harder. I stepped closer but didn't grab her. 10 seconds. Then she sat back down abruptly, breathing hard. Her father's jaw tightened, but he stayed still. Emma stared at her legs like they'd just confessed something. "I was standing," she said. "Yes," I replied. "For real, yes." She laughed once short and almost disbelieving. Hale exhaled slowly. Document duration and quality. He told the therapist, but his voice had changed. Less guarded, more analytical in a different way. That day, the EMG patterns showed stronger, more organized recruitment under load. Not perfect, not symmetrical, but consistent with voluntary activation. Over the next 2 weeks, we built on that. First step between the bars with therapist support at the pelvis. Second step with only light contact. Some days she regressed slightly. Some days she improved more than expected. But the direction was clear. By week 6, she could stand without bars for 15 seconds if the room stayed quiet. By week 7, she took 2 assisted steps outside the therapy room in a hallway where strangers walked by without staring. That detail mattered. Neutral environment. No performance. The first independent step happened on a Friday afternoon. No harness. No bars. Therapist within arm's reach but not touching. She shifted her weight forward. Right foot lifted. Cleared the ground. Set down in front of her. Clean. Her left followed. 2 steps. Then 3. She stopped there, breathing hard but steady. No one clapped. No one cried. We'd all agreed not to make it a spectacle. Emma looked at her father. He nodded once. That was all. Hale reviewed the documentation that evening. 5 independent steps with observable voluntary recruitment. He read aloud from the therapist's note. He looked at me. "There's no structural explanation for that level of function." I know. He didn't argue this time. By week 8, the number was 5 consistent independent steps in a controlled environment. Not a marathon, not a miracle. 5. But 5 is more than 0. And in medicine, 0 to 5 is sometimes the longest distance anyone travels. The morning after she took 5 independent steps, the email arrived before I finished my first cup of coffee. Subject line, internal case review. Callahan. No emojis. No exclamation points. Just policy. The meeting was scheduled for 10:30 a.m. Conference room A this time. Bigger room. That's never a coincidence. When I walked in, Dr. Hale was already there. Cynthia Morales sat at the head of the table. Thomas Whitaker from legal had a stack of documents in front of him, neatly aligned like he was preparing for a deposition instead of a clinical discussion. Emma and her father were not present. "This part of medicine rarely includes the patient," Cynthia began. "We are reviewing the documentation surrounding Emma Callahan's case to ensure clarity and compliance." Clarity and compliance. Translation. What exactly are we admitting to? Whitaker adjusted his glasses. The phrase permanent motor impairment appears in prior records from multiple institutions. Our responsibility is to determine whether that terminology reflected the standard of care at the time. Standard of care is the legal shield. Dr. Hale spoke calmly. At the time of initial diagnosis, imaging findings were ambiguous. No definitive structural lesion was documented. And yet permanent was used, Whitaker said. Yes, Hale replied. In the context of non-progressive symptoms over 2 years. I listened without interrupting. Whitaker turned to me. Dr. Donovan, your documentation states motor findings inconsistent with complete structural lesion. Yes. Are you alleging prior misdiagnosis? No, I said evenly. I am describing current findings. He nodded once. Important distinction. Cynthia folded her hands. The concern is how we communicate evolution in diagnosis without implying negligence. Negligence is the word everyone avoids until it appears in a lawsuit. Dr. Hale leaned forward slightly. Functional neurological disorder is increasingly recognized in pediatric populations. Underdiagnosis is common. Whitaker raised an eyebrow. Does that mean previous providers failed to meet the standard of care? It means medical understanding evolves, Hale said carefully. I added, diagnostic momentum is real. Once a label enters the chart, subsequent evaluations can unconsciously confirm it. Whitaker scribbled a note. Diagnostic momentum is not malpractice. No, I agreed, but it can limit reevaluation. Cynthia looked at me. Rachel, when you first observed voluntary recruitment, did you consider the institutional implications? Yes. And I documented objectively. That answer hung in the room. Whitaker opened another folder. There is also the matter of insurance coding. Disability classification influenced coverage decisions for nearly 9 years. I didn't respond to that. That wasn't my lane. Dr. Hale exhaled slowly. The current plan is structured rehabilitation under FND protocol. Imaging remains stable. No structural pathology identified. Whitaker tapped his pen again. Then our language should reflect evolving clinical interpretation rather than error. There it was. The approved phrase. Cynthia nodded. We will update her problem list to reflect functional neurological disorder with motor subtype. The term permanent will be removed. Removed. That word felt heavier than permanent had. Whitaker continued. We recommend an addendum clarifying that prior assessments were based on information available at the time. Hale met my eyes briefly before speaking. I will write the addendum. That mattered. The meeting ended without raised voices. No one accused anyone of incompetence. No one apologized. Hospitals rarely operate in absolutes. They adjust. When I left Conference Room A, I ran into Commander Callahan in the hallway. He had that same composed posture, but his eyes were sharper now. How'd it go? He asked. They're updating her diagnosis, I said, meaning functional neurological disorder. Motor subtype. Permanent is being removed. He held that information for a second. So no one was wrong, he asked. That's not how this will be written, I replied. He studied my face. But someone was incomplete. Yes. He nodded once. That's a fair word. We walked together toward the therapy wing. Emma was already there, standing between the parallel bars without the harness. 5 seconds. 8. She sat back down on her own. Her father didn't clap. He didn't rush to her. He stayed neutral, just like we'd practiced. Later that afternoon, Dr. Hale forwarded me the draft of his addendum. Prior classification reflected stability of symptoms without progression. Subsequent evaluation demonstrates preserved voluntary motor recruitment consistent with functional neurological disorder. Clinical interpretation has evolved. No blame, no confession, just evolution. I signed off on my portion of the documentation. By the end of the week, her electronic chart no longer displayed permanent motor impairment at the top of the problem list. Instead, it read, Functional neurological disorder, motor subtype. That change altered how every future provider would approach her exam. Not broken, not static, functional. Commander Callahan requested no litigation, no press, no statements. I don't want compensation, he told Cynthia during a separate conversation. I want process. Process had already begun to shift. The hospital circulated a quiet memo recommending FND screening before assigning long-term static motor classifications in pediatric cases without definitive structural evidence. No public announcement, no apology tour, just a policy update. Medicine rarely dramatizes its corrections. It revises quietly. The following Monday, Emma walked 5 independent steps in the therapy hallway while 2 nurses passed by without even looking up from their conversation. That detail mattered more than applause ever could. Neutral environment. No spotlight. 5 steps. I stood at the end of the hallway pretending to review a chart just in case she lost balance. She didn't. And for the first time since this case began, the tension in my chest wasn't about whether she could move. It was about how easily we had decided she couldn't. I stood at the end of the therapy hallway pretending to review a chart, even though I had already memorized every line of hers. Emma shifted her weight forward again. Right foot lifted. Set down. Left foot followed. 5 steps. Controlled. Deliberate. No harness. No bars. The nurses walking past barely noticed. One was talking about lunch. The other was complaining about the lab turnaround time. Normal hospital noise. Ordinary. That was the right environment. Emma stopped on her own and sat in the chair the therapist had positioned behind her. She wasn't smiling wildly. She wasn't crying. She looked thoughtful. "That feels different now," she said. "How?" I asked. "Less like I'm sneaking," she replied. That might have been the most accurate description of FND I'd ever heard. Her father approached carefully, not rushing in. "How many 5s?" she said. He nodded once. "Good. Not amazing. Not unbelievable. Just good." Dr. Hale joined us a few seconds later. He watched her posture, her breathing, the way she settled into the chair. "Duration?" he asked the therapist. "Stable through 5, she replied. He nodded. "Document consistency." Emma looked at him. "So I'm not permanently broken," he didn't hesitate. No. That word carried more weight than any diagnosis code. Over the next few days, the improvements held. Not dramatic leaps. Not 10 steps to 20 overnight. Just repetition without collapse. There were still moments when her leg felt heavy. Still days when initiation took longer. But the complete shutdown we saw in week 1 didn't return. The official discharge summary reflected her progress carefully. Patient demonstrates voluntary motor recruitment with graded weight-bearing tolerance. Findings consistent with functional neurological disorder, motor subtype. Continued outpatient therapy recommended. No fireworks. No declarations of cure. Just accurate language. Before she left the hospital for outpatient rehab, Emma asked to walk from her room to the elevator. "No audience," she said. We kept it small. Her father. The therapist. Me. She stood. 1 step, 2, 3, 4, 5. She paused, recalibrated, then took a 6th. I didn't correct her. At the elevator, she leaned back into the chair and exhaled. "It's weird," she said. "I thought if this ever happened, it would feel huge. It feels normal," I asked. "It feels like it should have always been like this." Her father swallowed but didn't speak. That afternoon, I finalized my last note in her chart. I avoided dramatic language. No phrases like remarkable turnaround or unexpected recovery. I wrote what was true. Initial ER presentation revealed preserved voluntary motor recruitment inconsistent with complete structural paralysis. Subsequent multidisciplinary evaluation supports diagnosis of functional neurological disorder. Functional mobility improving with graded therapy. That was enough. A week later, I received an internal update. The hospital had revised its pediatric motor impairment documentation guidelines. The term permanent would require explicit structural evidence and second review. FND screening checklist added before long-term classification. No headline, no announcement in the lobby, just policy revision. Dr. Hale stopped by my office that same day. "You pushed," he said. "I observed," I replied. He gave a faint half smile. "Most people don't observe when the chart already speaks loudly." "Charts don't examine patients," I said. He nodded once. "Be careful. Always." He left it there. A month later, Emma returned for follow-up. She walked into the clinic with a slight limp and no wheelchair. No one in the waiting room reacted dramatically. That was the point. In the exam room, I repeated the same neurological tests I had done that first night. Reflexes intact. Tone appropriate. Voluntary recruitment clean and coordinated. When I asked her to lift her right leg, she did. No imagery cue needed. "How does it feel now?" I asked. She thought for a moment, like it's mine. Her father sat quietly beside her. No tension in his shoulders this time. "I appreciate what you did," he said as the visit wrapped up. "I didn't fix it," I replied. "You questioned it." That part was true. After they left, I sat alone in the exam room for a few seconds longer than usual. This case wasn't terrifying because of blood loss or cardiac arrest, or a crashing trauma bay. I've handled those. It was terrifying because it exposed how easily medicine can harden around a word. Permanent. Permanent is efficient. It closes loops. It simplifies care plans. It stabilizes expectations. It also discourages curiosity. Emma's case didn't prove that every long-standing diagnosis is wrong. It didn't turn me into someone who distrusts specialists or imagines hidden cures everywhere. It reminded me of something quieter. When a diagnosis becomes identity, we stop testing it. When a label becomes administrative truth, we stop examining it. The most dangerous part of her chart wasn't the ambiguous MRI or the cautious consult note. It was the moment the word permanent stopped being questioned. I still work the same ER shifts, same fluorescent lights, same monitors, same overnight pages. But now when I see that word in a chart, I pause. Not because I assume it's wrong, because I know how easy it is for it to be comfortable. Emma didn't need a miracle. She needed space for her brain to feel safe enough to try again. And sometimes the difference between never and not yet is just one physician willing to look at a moving toe and refuse to call it nothing. I still think about that night sometimes, usually around 2 in the morning when the hospital gets quiet and the monitors start to sound louder than they are. I've handled trauma strokes, cardiac arrests. Those cases are intense, but they're clear. You see the problem. You act. You move on. Emma's case was different. It wasn't loud. It wasn't dramatic. It didn't come in by ambulance with flashing lights. It came in with a word already written in the chart. Permanent. What shook me wasn't that multiple doctors had evaluated her. It was how reasonable each step had been. No one ignored her. No one dismissed her. Every provider made decisions based on the information they had at the time. That's how hospital medicine works. We build on prior notes. We trust prior assessments. We move fast. But sometimes that trust becomes inertia. As doctors, we're trained to look for pathology. As soon as we find a label that explains the pattern, we feel relief. The system feels relief. Insurance feels relief. The family gets an answer, and answers are powerful. The danger is that answers can harden. In this case, the biggest lesson wasn't about functional neurological disorder. It wasn't about EMGs or MRI interpretation. It was about language, about how one word in a chart can shape 9 years of care, about how stable can quietly turn into unchangeable. Working in a hospital long enough teaches you something uncomfortable. We don't usually fail because we don't care. We fail because we stop rechecking assumptions that seem settled. Emma didn't need someone to save her. She needed someone to ask one more question. Before you try to move, what does it feel like? That question didn't require new technology. It didn't require a groundbreaking procedure. It required attention. If you follow nurses' stories or real-life cases about doctors inside the hospital, you already know the scariest moments aren't always the ones with the most blood. Sometimes the scariest moments are quiet. They happen in exam rooms, in documentation, in words we type without realizing how final they sound. This case changed how I read charts. It changed how I use the word permanent. And it reminded me that medicine isn't just about diagnosing what's wrong. It's about staying curious enough to notice when something doesn't fully add up. If stories like this matter to you, real hospital cases, real doctors making imperfect decisions, real patients pushing back against labels, make sure you're subscribed. These nurses' stories and ER experiences don't get told in textbooks. They get told by the people who were standing there when something small changed everything. And sometimes that change starts with a toe that moves when everyone assumed it wouldn't.